Good day to all. This is my second video regarding brain anatomy, blood supply, and stroke. In this video, we will focus mainly on the localization and management of stroke. I would strongly recommend you to watch my previous video where we have discussed at length about the brain's anatomy, its blood supply, and the more fundamental concepts of stroke. So now let's begin.
So now we shall discuss localizing strokes. So as we've seen in the image above, that is over here, there are many different arteries and each of them supply different areas of the brain, right? So based on the structures present in the areas that are supplied by these arteries and the deficits caused by the lack of blood supply to those parts, we can make a very educated guess as to which parts of the brain are affected. And this localization helps because the eye sees what the brain knows. Right, so if you already look at the imaging with some information in mind, you are more likely to identify the stroke. Or in places where imaging is not available, these symptoms can help you localize the stroke. So coming to the strokes, the first thing will be the medullary strokes. And in medullary stroke, the first one I would like to talk is the medial medullary syndrome. The entire discussion about localization of the stroke starts off with the artery that is involved, what it supplies and what it causes if the supplied part is damaged. Right. So as previously discussed, it is the anterior spinal artery that supplies the medial medulla, and if this anterior spinal artery is blocked, we will get the medial medullary syndrome or the Dejerin syndrome. It is this part of the medulla. Now this image is taken at the upper borders of the medulla, right? As mentioned here, it is at the level of the auditory nucleus and at the floor of the fourth ventricle. So the structures that are affected here are the pyramid, the medial lemniscus, the hypoglossal nucleus, and the medial longitudinal bundle and tectospinal tract. So because the pyramids are damaged, there is contralateral hemiplegia. Because there is the medial lemniscus that is damaged, there is vibration and proprioception loss. The medial lemniscus carries sensory fibers from the body to the brain. The pyramids carry motor fibers from the brain to the body. And then also, since there is the hypoglossal nucleus that is damaged, you will find tongue paralysis. Now, tongue paralysis, when it occurs, the opposite-sided muscles of the tongue become stronger and thereby cause the tongue to deviate to the side of the palsy, right? So that is the cranial nerve damage. Now coming to the lateral medullary syndrome that occurs due to the posterior inferior cerebellar artery block. So it will be this area of the brain that is damaged. Also, since we have done our rule of 12 and rule of 4, we can easily say that the medulla will have 9, 10, 11, 12, right? Out of which 12 is in the middle and is already accounted for. So 9, 10 and 11 are to be taken care of, right? This 9, 10 and 11 will be seen in the nucleus ambiguous. The nucleus ambiguous. And another thing to keep in mind is that while talking about cranial nerve 11, most of us assume that its only function is the shrugging of shoulders. That is a function of the spinal component of the accessory nerve. The cranial component will help in innervation of the muscles of the pharynx and larynx. So, damage to the 9, 10, 11 cranial nerve will cause paralysis, ipsilateral paralysis of most of the muscles of the soft palate, larynx and pharynx. There is also ipsilateral pain and temperature loss on the face because of the trigeminal nerve, nucleus and tract damage. This particular nucleus and tract of the trigeminal nerve spans through all parts of the brainstem. Right, if you look at this entire diagram, you can find the trigeminal lemniscus even in the midbrain. You can find the spinal tract even in the medulla. You can also find the trigeminal spinal tract even in the pons, right? So it is present everywhere. So ipsilateral pain and temperature loss on the face because of damage to the spinal nucleus of the trigeminal nerve. Then there is contralateral pain and temperature loss in the body because of the spinothalamic tract damage. Right, this is spinothalamic tract. The spinothalamic tract crosses a few levels after it reaches the spinal cord, whereas the vibration and proprioception that comes from the fasciculus gracilis and fasciculus cuneatus crosses in the medulla at the level of the sensory decussation. And then there is also vertigo. Now, vertigo is because there are parts of the eighth cranial nerve nucleus over here. Yeah, the vestibular nuclei are present here, and this gives the vertigo component. And there is also loss of equilibrium and ataxia of the limbs on the same side because the inferior cerebellar peduncle is damaged. Right, the inferior cerebellar peduncle. These are the medullary strokes. Now coming to the pontine strokes. Normally, if a pons lesion is present, you will see a pinpoint pupil because of the damage to sympathetic ocular fibers, hyperpyrexia because temperature regulating fibers at the hypothalamus are damaged, and there is also tachypnea because of damage to the respiratory centers. Right. Now, anterior inferior cerebellar artery. Now, this anterior inferior cerebellar artery supplies the 7th and 8th cranial nerve, anterior inferior cerebellum, and part of cranial nerve 5. So the defect if it is blocked is the lateral pontine syndrome. These are the dorsal and ventral cochlear nuclei. This is the vestibular nucleus. The inferior cerebellar peduncle. Again, there is a trigeminal nucleus that is damaged in the lateral pontine syndrome. Spinothalamic tract, facial nerve. Now, one thing that we note is that irrespective of whether the medial part of the pons is damaged or the lateral parts of the pons is damaged, there is a facial nerve damage. Now, the only difference being that in the lateral aspect, it is the element sort of lesion because the nucleus is safe. And in the medial part, the nucleus is damaged. So it is a UMN type. Right. So facial lesions are specific. There is decreased salivation, lacrimation, and taste from the anterior 2/3 of the tongue. Right. Since cranial nerve 8 is damaged, there is vertigo and nystagmus. Again, spinothalamic tract is damaged, so there is decreased pain and temperature from the contralateral side of the body. And face is and in face there is ipsilateral decrease in pain and temperature, again because of the spinal trigeminal nucleus damage. Now, when it comes to the basilar artery is the one that supplies the medial aspect of the pons, right? And when the medial aspect of the pons is damaged, quite a few structures are damaged. And this will cause the popular locked-in syndrome as well. Where only vertical movements of the eye is allowed. So that is the locked-in syndrome. So the symptoms of a medial pontine disease is decrease in consciousness if reticular activating system is damaged. Now, the reticular activating system is the white matter tracts that are diffusely found in the pons, and these maintain consciousness. They are more found in the medial aspect of the pons. So, if this is damaged too much, there will be loss of consciousness and the patient falls into coma. Now, since the facial nerve nucleus per se is damaged, it causes a decrease in voluntary movements of the face, tongue, and mouth. Then there is quadriplegia, simply because there is damage to the corticospinal tracts. These are the motor tracts that come from the cortex and goes to the spinal cord and muscles. So since this is damaged in the medial aspect, there is quadriplegia. And since there is the abducens nucleus that is damaged, there is horizontal eye movement loss. So if you find these symptoms, think of it as a pontine stroke. Now coming to midbrain syndromes. Now the midbrain per se is supplied by the superior cerebellar artery and the posterior cerebral artery, right? And most of the midbrain syndromes are involving the third cranial nerve. Third cranial nerve palsies are characteristic of midbrain syndromes. The named syndromes among them are the Weber syndrome, Bendix syndrome, and Perinaud syndrome. So the Weber syndrome presents with hemiplegia on the opposite side because again the corticospinal tract is damaged, and then the pupil points downwards and laterally due to paralysis of the third nerve. Then coming to Benedict syndrome. Benedict syndrome is again tremors and twitching because of damage to red nucleus and superior cerebellar peduncle on the contralateral side, these symptoms present. And then there is again the pupil points downwards and laterally due to the paralysis of the third nerve. And then there is Parinod syndrome. Now, Parinod syndrome usually occurs if there is compression of the superior colliculus, especially from behind. So this leads to weakness in upper gaze and vertical nystagmus, and this is because of the superior colliculus damage. Now coming to the cortical strokes. That is strokes of the cerebral cortex. So starting off with the posterior cerebral artery, the posterior cerebral artery will supply the occipital lobe, and the occipital lobe is concerned with vision, right? So any block in the posterior cerebral artery will cause contralateral hemianopia with macular sparing, right? The contralateral hemianopia is because of how the nerves from the optic nerve come into the occipital lobe, and the macular sparing is simply because the MCA supplies the cortex that deals with the central vision of the corresponding eye. In case the posterior cerebral artery is damaged, entire peripheral vision goes off. I mean, not the entire peripheral vision, but the loss of vision would be somewhat like this, right? So here there will be the macular sparing. And if both the posterior cerebral arteries are damaged, even then the central vision still exists. So in this case, the patients usually believe that their sight will return. Another symptom that we can see is alexia without agraphia. Alexia is the inability to read, and agraphia is the inability to write. But over here, the people who are suffering from the posterior cerebral artery can write, because writing is a parietal lobe function. Right. Now coming to the middle cerebral artery. Right. The lateral aspect of the brain is called the middle cerebral artery's territory. And this lateral surface of the brain will have the sensory and motor fibers of the body, face, and upper limb. And it is the medial aspect of the brain that will have the motor and sensory components of the lower limb and the groin regions. So, damage of the middle cerebral artery will cause motor and will cause contralateral paralysis of the face and upper limb, and even the upper body. So, if the dominant hemisphere is damaged, there will be aphasia, and if the non-dominant lobe is damaged, there will be hemi-neglect. Right. There is also the aspect of visual field loss due to the temporal lobe involvement. Now, since this lateral aspect completely involves even the temporal lobe, and there are fibers that cross this way, so damage to those optical fibers will cause a pie in the sky sort of blindness. And frontal eye field damage, again the frontal eye field is a part of the frontal lobe over here, and this damage will cause eye looking away from the hemiplegia. And since the eye is looking away the hemiplegia, and the hemiplegia is contralateral, the eye looks towards the lesion. You can say, and also now that we are talking about eye looking towards the lesion or away from the lesion, when we talk about basilar artery block, the PPRF is damaged, and that causes the eye that looks toward the hemiplegia or away from the brain lesion. Right. Now coming to the anterior cerebral artery. Now the anterior cerebral artery supplies the medial surface of the cerebral cortex. Right. This entire area is supplied by the anterior cerebral artery. And this area takes the lower limbs, motor and sensory functions also. So damage to this will cause contralateral paralysis and sensory loss of the lower limb, and also urinary incontinence. And since the frontal lobe is damaged, personality change is also seen. There is disinhibition, impulsivity, and loss of empathy, and there is also hyperphagia. Now, this should be contrasted with the amygdala damage that will cause Kuver-Bucy syndrome, and that is hyperphagia, hypersexuality, and hyperorality. Now, both of them might be personality changes, but these differences must be kept in mind. Right, because amygdala is more towards the temporal lobe side, and this is the frontal lobe side. So confusing between these symptoms can cause a mistake in localizing the disease. Now that we've completed the previous discussion over here that talks about cortical strokes, and we've also completed discussion where the brainstem is involved, we have completed a bulk of our localization discussions. Over here, I would like to talk about some extra pointers. Right. So if the stroke is a purely sensory stroke, think of it as the thalamus damage, as in Dejeron-Rusi syndrome. We can think of a purely sensory stroke being the thalamus because the thalamus per se is the relay center of all the sensory neurons first come and relay and the thalamus and then go to further parts of the brain wherever required. So damage to the thalamus, especially without any of the cortical signs, will be Dejeron-Rusi syndrome. Next, coming to hyperkinetic disorders such as chorea, athetosis, and hemibalismus. Now, chorea is more of a jerking movement. Chorea implies damage to the caudate nucleus. Then there is athetosis. Athetosis is more of a wringing movement, that is like how you twist your wrists or how you twist your digits, right? It occurs mostly in distal limbs. And athetosis implies damage to the globus pallidus. Then coming to hemibalismus. Hemibalismus is a flinging sort of movement, as if you're trying to throw something. This also occurs in the limbs, but this is the more violent of the movements. Right. And hemibalismus indicates damage to the subthalamic nucleus. Now, symptoms such as agraphia, acalculia, and finger agnosia will happen if the dominant parietal lobe is damaged. And that is what is seen in our middle cerebral artery stroke. Right. So the middle cerebral artery, if it damages the dominant parietal lobe, you can see these acalculia, finger agnosia, and agraphia. Agraphia is the inability to write, acalculia is inability to do math, and finger agnosia is inability to perceive one's own fingers. Right. So that is what finger agnosia is. And if the same MCA of the non-dominant lobe is damaged, you think of hemispatial neglect. Now, this hemispatial neglect will manifest like the patient will take care of only one side of his face or dress well only on one side of the body, whereas the other side will simply be left disheveled. Or if you want to make the patient to do a test, tell him to draw a clock. Right. A normal person will draw the entire clock like 12, 3, 6, 9, and the remaining. But in a patient with hemispatial neglect, he might draw, but then it will be somewhat like this. So everything is towards one side, and only that side will be dealt with, and the other would be neglected. Right. Now coming to tremors at rest. Now tremors at rest, especially when Parkinson's-like symptoms are involved, would mean basal ganglia damage. Again, hyperphagia, hypersexuality, and hyperorality, or the Kuber-Bucy syndrome, would be damage to the amygdala. Now, since we have talked about tremors at rest, if you contrast it with intention tremors. Now, tremors at rest simply means that when the person is just sitting or not doing anything, there are tremors. Intention tremor is tremors not being present at rest, but as soon as the person begins to perform an action, the tremors begin. Right, so this case would mean a cerebellar damage. And other symptoms could be limb ataxia or loss of balance on the ipsilateral side. Remember, all cerebellar lesions will have ipsilateral effects. And then let us say that truncal ataxia, nystagmus, and dysarthria, it is a vermis damage. Now, vermis is the centralmost part of the cerebellum. And the centralmost part of the cerebellum deals with all the central aspects of balance, that is truncal balance, the eyes, or speech, right? So thereby you can make the relation, and this also helps you remember. Now coming to the last aspect, that is the management of stroke, right? Now, even though we have put so much pains and efforts into understanding the localization of stroke, when it comes to management, the area in which it is present is irrelevant because we give the same treatment irrespective. The treatment per se is to administer IV recombinant TPA at 0.9 grams per kg over 60 minutes, with 10% of it given as a bolus dose within the first 10 minutes. Right. So this is done in hopes that the clot breaks down. And the only way in which we can see that the clot has broken down and perfusion has been restored is a neurological exam. And this neurological exam must be done for every 15 minutes during the infusion and every 30 minutes for the next 6 hours. Right. If the patient is hypertensive, target blood pressure reduction to 180 mm of Hg systolic. Right. A higher blood pressure target helps in increased perfusion of blood. So blood pressure can be reduced by using labetalol or esmolol, which are the first line drugs, or second line drugs also can be used as nitroprusside and hydralazine. Now, if the blood glucose is less than 60 mg per deciliter, it must be increased by giving glucose infusions. And in hyperglycemic patient, target ranges of around 140 to 180 milligram per deciliter. Right. Keeping the glucose mildly above could mean that extra glucose going to the brain can help. Reduce the fever using paracetamol if the temperature increases greater than 38 degrees centigrade. And if facilities are available, try for endovascular therapy even in patient undergoing this above thrombolysis. Right. Endovascular therapy is basically a stent that goes through the blood vessels. Right. Let us say it is this blood vessel that is damaged. So the endovascular therapy would go through the blood vessels, go till the damaged blood vessel, and then either try to suck out the clot or release a thrombolytic right into the same blood vessel, thereby reducing the chances of side effects and increasing the chances of success. Another thing we need to keep in mind is we need to first check if the patient qualifies for the RTPA therapy. Right. There is an exhaustive list of inclusion and exclusion criteria, but some of them, and that is the most important of the inclusion eligibility criteria, are the diagnosis is an ischemic stroke, because let us say it's a hemorrhagic stroke and you give a thrombolytic, you are breaking the clot that might have formed to stop the excess leak of blood, thereby worsening the situation. The second point that is written here, there is no evidence of infarct on CT, is wrong. It is more likely that it is no evidence of hemorrhage on non-contrast CT, and there is a measurable neurological deficit.
So this is all about brain anatomy, blood supply, and stroke. I have done my best to present all the information in a simple and diagram-heavy manner,
with the hope that I can help you deal with your fear of stroke.
I hope I have helped. Thanking you, and until we meet again. Goodbye.